Sleep disorders. This is a PowerPoint presentation on sleep disorders, focusing on the biopsychosocial model of sleep disorders with treatment recommendation. Contributing factors are biological, psychological, and social causes of sleep disorders. Sleep deprivation. Sleep is essential for physical and mental performance and consists of two alternating stages: non-rapid eye movement sleep and rapid eye movement or paradoxical sleep. Sleep deprivation can be acute, which involves continuous sleep deprivation in the range of several hours up to a week, and the other form is chronic, which is characterized by daily sleep deprivation for several hours, typically 3 to 8 hours a day, that lasts for weeks or months. Poor sleep quality is associated with numerous mental health concerns. Public safety personnel may be most at risk of developing sleep problems due to long work hours and exposure to trauma. However, sleep disorders can affect anyone at any time of their life. Let's look at biological factors. Patients with major depressive disorder and schizophrenia are known to have some common sleep architecture abnormalities, including increased sleep latency, decreased total sleep time, and decreased sleep efficiency index. Additionally, insomnia can influence the trajectory of depression, affecting the severity, duration, and relapse rates of the disorder. Psychological factors. Many studies have found that sleep disturbance, such as shorter sleep time and lowered sleep quality, is associated with increased psychotic experiences in clinical, non-clinical, and at-risk populations. Additionally, the evidence to date does indicate that sleep disorders are an important clinical issue in psychosis, with insomnia as by far the most researched sleep disorder has shown to be common, severe, and importantly treatable in patients with psychosis. Compared with not having a sleep disorder diagnosis, having at least one sleep disorder was significantly associated with more severe paranoia, hallucinations, and cognitive disorganization. Medication use is an important factor in considering sleep in individuals with psychosis, since antipsychotic medication may improve sleep. However, daytime sedation is common, and antipsychotics may themselves increase risk of certain sleep issues such as sleep apnea. Let's look at some social factors. There is a suicide prevalence. Suicide is a major public health problem worldwide. Globally, it is estimated that more than 800,000 people died of suicide in 2012, and more than 1 million people died of suicide in 2016. In the United States, suicide is the second most common cause of death in people aged 15 to 34 years old. Similarly, in China, suicide is the leading cause of death in people in the same age group. Millions of individuals are bereaved by suicide every year, and suicide prevention has overwhelming significance for global public health. So let's look at suicide and insomnia. The Institute of Medicine has made suicide prevention a top priority and called for measures to explore evidence-based risk factors to reduce national suicide rates. To date, many risk factors have been described, including unchangeable and potentially changeable factors. Unchangeable factors include age, gender, and severe physical illness, whereas changeable factors include previous suicide attempts, harmful use of alcohol, and insomnia symptoms. Among these factors, global or partial insomnia is an important risk factor for suicidal behavior, but it has generally been overlooked in previous reviews of suicide risk factors and suicide prevention. Psychosocial factors. In addition to pathophysiological explanations, psychosocial factors such as unemployment, divorce, and circadian rhythm disorders could directly aggravate sleep disorders and depression. Hypotheses. Serotonin dysfunction is presumed to be an important physiological factor for the association between sleep disorders and suicidal behavior in depressed patients. Other hypotheses, including the involvement of the hyperactive hypothalamic pituitary adrenal axis and the overactivity of the noradrenergic system, were also described as pathophysiological mechanisms of increased suicide risk in patients with depression and sleep disorders. What are some other medication treatments? There are the 5-HT2A antagonists. Two 5-HT2A antagonists, nefazodone and trazodone, cause sedation and promote sleep. In small unblinded studies, trazodone has been shown to promote sleep and reduce nightmares in PTSD and depressed patients. Possible side effects. However, the use of trazodone is limited by common side effects, including cognitive and motor impairment and tolerance. Let's look a little bit at inadequate sleep and neurodegeneration. Sleep and neurodegeneration. The relation between sleep and neurodegenerative diseases is bidirectional. Neurodegeneration is accompanied by sleep difficulties due to reduction of amplitude and phase changes of circadian rhythms, such as that of melatonin secretion, as well as the disturbing influences of neurodegenerative processes on sleep. Inadequate sleep. Conversely, inadequate sleep in terms of both duration and quality increases the neurodegenerative process and aggravates the underlying clinical picture. Several studies have shown that sleep disruption is a major contributor to neuropathology. What are additional medication treatments? There's the group of SSRI and SNRIs, so selective serotonin reuptake inhibitors, the SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, are recommended as first-line treatments for PTSD. However, the effects of SSRI, SNRI on sleep are typically modest or even adverse. Benzodiazepines. Benzodiazepines are commonly used but controversial in the treatment of insomnia. A recent meta-analysis revealed that short-acting benzodiazepines have modest beneficial effects on sleep and PTSD. Their use is not recommended due to the emergence of tolerance and their association with depression, aggression, and worse psychotherapy outcomes. One suggestion that may work is cognitive behavioral therapy. Non-pharmacological treatments may be more effective to treat insomnia in individuals with PTSD than pharmacological treatments. Cognitive behavioral therapy for insomnia is the frontline treatment for insomnia and shows promise in PTSD patients. CBT is a protocol typically involving sleep restriction, stimulus control, or instructing patients to use bed for sleep only in order to strengthen the association between bed and sleep, sleep hygiene, or modification of dysfunctional thoughts about sleep. There are non-pharmacological treatments, and one of the best is melatonin, and we'll explore that a little bit in the next few slides. Melatonin, which promotes the metabolism of many reactive oxygen species, has antioxidant and neuroprotective properties. Melatonin-free radicals. Melatonin has the ability to neutralize free radicals and to prevent tissue damage associated with oxidative stress by utilizing different mechanisms that include scavenging the free radicals. Another factor to consider is comorbidity with obesity due to the melatonin rhythm being disrupted. So what is the melatonin rhythm? The melatonin rhythm has the potential role that the circadian rhythm system, including the sleep-wake cycle and the melatonin rhythm, may play in determining the accumulation of fat. Why is that? Let's look at the biological clock. The vertebrate biological clock is located in neurons in the suprachiasmatic nuclei of the anterobasal hypothalamus. The SCN is the chronometer that determines the regular fluctuation of virtually every function in the organism. It is the central generator of circadian rhythms. Melatonin is a natural compound. Melatonin is a naturally occurring compound that is found in animals, plants, and microbes. It is released from the pineal gland during dark periods and is suppressed upon exposure to daylight. As an antioxidant, melatonin reduces the formation of free radicals. The antioxidant effect has been previously observed during acute sleep deprivation-induced memory impairment. Circadian rhythm and melatonin secretion. There are specific receptors for melatonin in the SCN that provide the feedback and adjust the amplitude and timing of circadian rhythms. Key clinical features of depression, in particular sleep disturbance and diurnal changes in mood, suggest that there is something awry with the internal body clock. Examination of physiological parameters in depressed patients have identified changes to the normal circadian rhythm of core body temperature, cortisol secretion, noradrenaline levels, thyroid stimulating hormone, and melatonin secretion. Therefore, melatonin is multifunctional processed. Melatonin appears to possess many functional processes related to phase shifts. When given in the afternoon, this hormone advances phase shifts in its endogenous synthesis and core body temperature. However, when administered in the early morning, melatonin delays the circadian system. Therefore, it is able to phase advance the endogenous circadian system according to a phase response curve in diurnally active people. What is a measurable rhythm? One easily measurable rhythm that is obviously disordered by alterations of the circadian clock is the sleep-wake cycle seen in the phenomenon of jet lag. Performing rapid transmeridian travel across multiple time zones, particularly in an easterly direction, requires the SCN to readjust its signal to the new light-dark environment after arrival, and during this period of readjustment, individuals experience sleep disturbance, jet lag, with conspicuous disturbances in the 24-hour melatonin cycle. Melatonin is a chemical expression. One obvious cycle that clearly depends on the prevailing light-dark cycle and the function of the SCN, regardless of their specific circadian activity pattern, experience elevated pineal melatonin production and secretion during the night, with minimal synthesis during the day. As a result, melatonin is often referred to as the chemical expression of darkness. Since pineal melatonin is quickly released once it is produced, the melatonin rhythm in the blood reflects its synthesis with the pineal gland. The conclusion is that sleep deprivation may happen at some point in a person's life, regardless of what comes first, a mental affliction that affects sleep or a sleep disorder that causes mental anguish or illness. Sleep deprivation can have serious consequences. This research concludes that melatonin may be the best solution for sleep deprivation. I hope you enjoyed my presentation, and I wish everyone a very good night.